Welcome back. Now we want to take a step back and talk about how sampling is done and what the implications are for not asking the right people the right questions. So let's consider an example. Say we are interested in sampling the water quality at any tap within a given territory, whether it be county or city, etc. We need to make sure that we draw a sample that is representative of the population of water taps in that region. To do this, we must be deliberate and careful not to let any biases enter our sample, making the conclusions we draw using methods discussed in previous sections potentially erroneous. In public health, this is particularly important because what if we conclude there is no toxin in the drinking supply, but we've drawn a poor sample and may have missed something? People could get sick and even die. When we take our sample, whether it be drinking water or cancer incidents among different racial groups, etc., we must be careful to have everyone represented somehow. In the example here, where there are houses, factories, and castles apparently, we would want to draw samples from each type of structure where people live and work. If we were to just take samples at the first tap we came across and called it a day, that would likely not provide the information we need for our work. Take, for instance, if, as researchers, we lived in an older part of town and decided just to draw a sample from our own tap. While there could be characteristics associated with homes in that part of town that affect the quality of water in a way that is different than in homes on the other side of town. So we could sample just homes or just factories or just castles for that matter, but if we do that, we leave ourselves open to bias and false conclusions. We should work to randomly select from each type so that our sample is representative of the target region. Now for some more vocabulary. A study design is a specific plan or protocol for conducting a study, which allows the investigator to translate the conceptual hypothesis into an operational one. The sampling frame is a list of the items or people forming a population from which a sample is taken, for example, students in a school. The sampling method is how the sample is drawn using systematic approaches such as the simple random sample, where the whole population is available, or the stratified random sample, in which there are specific subgroups to investigate, for example, race, gender, etc., or the systematic random sample, typically used when a stream of representative people are available, for example, a line in the street. External validity is a generalizable inference in scientific research, or the extent to which the results of a study can be generalized to other situations and to other people. The decision on which design to use is based on several factors. The question being asked, the availability of data, funding. This is the simple biggest factor involved in the decision on how to design a study, specifically the size and characteristics of the sample drawn. Also, the breadth and quality of previous research, along with epidemiologic information such as the outcome prevalence as well as the exposure prevalence. In designing our study, we can choose to systematically review previous work using proven methods, randomly expose study subjects and observe outcomes, identify and follow individuals over time, continually collecting data, identify subjects by exposure status and follow, identify subjects by outcome status and collect history, survey the population asking questions about exposures and outcomes, or compile and study case reports. All of these approaches carry with them strengths and limitations that affect the decision to use them. One measure of a study design is its ability to offer strong conclusions. The pyramid here illustrates the range and strength from the case series design on up to the meta-analysis, which systematically uses results from many previous studies to create aggregate test statistics that can be used to draw strong conclusions. Let's talk about conclusions for a minute. Our goal is to confirm or deny a causal relationship between exposure and outcome, but this is very difficult to accomplish and is therefore rarely the conclusion we come to after a study is complete. Often we are producing correlational information, which does not imply causation. Causation is the last conclusion made in research and is typically not ever stated directly, even after decades of research and many independent studies. This is the nature of observational research. We can't ever account for all of the possible factors influencing health. Here's a fun example. Ice cream sales are correlated with forest fires based on statistics captured across several years. Does this mean then that after firemen go and put out forest fires that they always go and get ice cream afterwards? Or how about firemen always eat ice cream on the way to put out forest fires? No. We, of course, are not suggesting either of those things. What is happening in this scenario is that both ice cream sales and forest fires are associated with summertime, a rise in average temperature. That said, the two things are correlated in that the data show them trending along with each other. It's important to understand what correlation means and its limitations. There are a set of guidelines to determining causal relationships that have been widely accepted. We can break this list of criteria down into major criteria and other considerations. Let's look closer at the major criteria. First, we have to establish a temporal relationship. In other words, for an exposure to cause an outcome, the exposure has to occur before the outcome. We have to be able to replicate the findings in multiple studies. The relationship has to be plausible. It's plausible that inhaling tar-riddled cigarette smoke would lead to a diagnosis of lung cancer. And finally, we have to consider alternative explanations for the observed relationships in order to rule out any other possible drivers of the outcome. Looking back at our pyramid of strength, we can now speak in terms of the causal criteria with regard to each study design's ability to address them. For instance, the longitudinal study design is very good at establishing a temporal relationship, arguably the best, really. In this design, study subjects are followed over time with data drawn at multiple points in time. So we can say for sure that an exposure did or did not exist in each individual study participant prior to the occurrence of the outcome of interest. This is all about the temporal challenge. If we want to talk about causation, we have to establish that the exposure occurred prior to the outcome. This is surprisingly difficult, as you will see. Let's talk about surveys. The source of so much of our health statistics these days. Nearly all of the major surveys are cross-sectional in design. That is, they take a snapshot of the population and attempt to establish correlational connections between exposures and outcomes. So why do we employ this type of design rather than one that is more powerful? The main reason is that cross-sectional study is very useful because it is relatively easy and inexpensive, at least compared to other study designs. We can survey the population and get our snapshot of what's happening, potentially arguing for additional studies. Its weaknesses lie in the lack of establishment of any temporal relationship between potential exposure and outcome factors. Conclusions are therefore limited to correlational, which should be considered with caution as there often is not an established comparison group. The longitudinal study design, on the other hand, follows study participants individually over time. Longitudinal study design is the gold standard for observational research. This model can most effectively establish the temporal relationship between potential exposure and outcome factors. Assuming results and hypotheses meet the other causal criteria, this design is the closest we come to determining a causal relationship in observational research. Longitudinal studies are very expensive and time-consuming. Now considering case control and cohort study designs, let's say there are two ways to assess the population and identify participants in our study. We can either select participants by exposure or by outcome of interest. For example, if we select our participants by exposure, then perhaps they might be categorized as smokers or non-smokers. This would be the cohort study design approach. We could also select by outcome, and in keeping with the example, this might be a diagnosis of lung cancer or none. Participants would be selected as cases, lung cancer diagnosis, and controls, no diagnosis. This, of course, is our case control study design approach. Within the cohort study design, we have two main categories, prospective and retrospective. The prospective approach identifies those with the exposure and those without, follows them over time, and notes if the outcome occurs or not. In the retrospective design, we use records or self-reported data to identify our exposure groups and assess each for their outcome. With any study, we must identify and consider our sampling frame, which is the group of individuals that are at all eligible for sampling. For example, students at a particular school, state residents, adults in the U.S., adults living in apartments, This is dictated by the purpose of your study as well as funding. Your sampling frame may also be dictated by the professional relationships or networks you've established. For example, if you have a contact within a specific school system, then you may choose to do your study within that student body. Once we have our sampling frame established, we need to decide on a sampling methodology. The most basic and straightforward method is the simple random sample. In this approach, every individual in the population is equally likely to be selected into the study. There are no stratifications by gender, race, or any other. We would just randomly select individuals from the target population. Now, in the stratified random sample, we have separate groups, in this case men and women, from which we want to randomly select an equal number of study participants. This allows us to get a sample that can effectively find similarities or differences between the two groups. In the systematic random sample, we are dealing with a movement of individuals through a system or space. For instance, if you wanted to sample folks coming through a farmer's market, you might want to select every third person for 20 minutes every other hour. This is done for several reasons. One being that your survey instrument may be too long and take too much time for you to be able to talk to every person coming through. Also, you may have personal biases that can affect the sample. If I'm more comfortable approaching women than men, my sample is going to be biased. The systematic approach removes my decision-making process. Let's talk briefly about validity, specifically external validity, as it is the most common measure of validity. There are actually several different types of validity, all of which are important to consider when drawing and analyzing the characteristics of a sample population. External validity is the kind of a general validity measure that describes the extent to which study results can be applied to the greater target population. It is not very useful for us to be able to describe the characteristics of our sample if they don't apply to at least a subpopulation of the community. Not much funding for that sort of thing. Threats to external validity include selection bias, measurement, observation bias, and historical effects. Selection bias is the most common threat to validity and is the product of faulty sampling methods. Consider the ninja and the cheerleader. If your sampling methodology is a general call for volunteers, would you expect the ninja or the cheerleader to be better represented in the sample? The cheerleaders are much more likely to be represented in the study, while the ninja contents him or herself to sneaking around looking for mayhem to cause. If our population includes both cheerleaders and ninjas, then our sample will not be representative. The message here is that we must make sure to select or allow selection for types of groups represented in the population. Random assignment of treatment and control serves to minimize selection bias as well. Measurement bias involves a question of asking the right question in a way that measures what I think it does. For example, there are many ideas about how best to measure and identify alcoholism. Short of a brain scan, there is no good way to directly observe alcoholism, only its presumed effects, for example, social isolation, legal entanglements, unemployment, etc. If we use a measure such as repeated legal problems, along with a measure of consumption, we could be identifying alcoholics or individuals suffering from the effects of racial bias from law enforcement, or both. It's important to fully understand the limitations of your measurement approaches when interpreting results of observational studies. This is not easily accomplished and is beyond the scope of this training module. The important thing is to understand that the way we identify characteristics of interest in our study population has a profound effect on the quality of our results. Observation bias is simply the effect on a thing caused by observing it. For instance, if we're attempting to identify people smoking and we go out looking for folks who are smokers, we may encounter a change in behavior caused by our observing folks in the population. People may not want to be observed smoking. Finally, we must be aware of any historical effects on our sample. Things can happen in the community over the course of sampling that can affect the validity of the results. Significant changes in public policy, natural disasters, housing market crashes, all of these things are out of the control of researchers and can influence the responses from people in the community who are affected by them. The only thing that can be done is to try and avoid these community level historical effects and to account for them when they occur. Okay, let's wrap it up. We've covered a lot in this module, yet we've left a ton to be discovered. I encourage you to build on the concepts presented here so that you can better make sense of the mountains of data available to you as public health professionals. Budgeting and funding are becoming more challenging every year, making it difficult to hire expert data analysts at the local and even regional levels. It is up to all of us to become savvy data managers so that the community gets the best, most effective services for their needs. Go ahead and take the assessment attached to this section of the module, and thank you for tuning in.